Good evening, everyone. Today we'll be discussing about the heart failure. So we see a lot of cases in our inpatient patient presenting with shortness of breath, dyspnea, pedal edema. That can be right heart failure or left heart failure symptoms to our OPD. And how do you treat such patient? What are the drugs we need to use? How do you classify the heart failure? So we'll be discussing that topic in the present session. So definition of heart failure it bus say any symptoms like breathlessness, ankle swelling or any fatigue or any shortness of breath, elevated JVP or pulmonary crackles or something. So caused by any structural function abnormality is defined as a heart failure per se. And heart failure per se is divided into heart failure with reduced ejection fraction where LVF is less than 40% or mildly reduced ejection fraction which is 41 to 49%. Heart failure with preserved ejection fraction is any LVF more than 50%. Along with the objective evidence of cardiac structural or functional abnormalities that can be due to the cardiac like left ventricular hypertrophy or diastolic dysfunction or any functional murmurs or functional regurgitation is present, anything with the presence of LV diastolic dysfunction or raised left ventricular filling pressures are including natriuretic, any raise in the natriuretic peptide also, like these are the markers of cardiac failure like raise in the NT-proBNP, BNP, TROPI. These are the biomarkers suggestive of heart failure. So anything with these signs without LVF is preserved but they have diastolic dysfunction or LV filling pressures are elevated. These are all the signs that there is some failure that is not associated with reduced ejection fraction. So these are the various stages of heart failure. One is stage A, at risk for heart failure. Stage B is pre-heart failure. Stage C is when symptomatic heart failure. Stage D is advanced heart failure. What is stage A? Stage A is any patient with hypertension or cardiovascular disease or diabetes or obesity or exposure to cardiotoxic like chemotherapy, and cardiotoxic drugs or any genetic cardiomyopathy risk factor is present, any family history of cardiomyopathy. These are all at risk of heart failure. These are all come under stage A. Per se diabetes, hypertension is there, they are at risk. They are stage A heart failure per se. So stage B is anything. Patient without any symptoms per se but evidence of structural heart disease. Some amount of diastolic dysfunction is there. Some mildly reduced ejection fraction is there. But there is no symptoms per se. But evidence of increased filling pressures is there. Left atrial pressure is elevated or something. Or associated with increased in natriuretic peptide or cardiac troponin elevated. So there is structural or functional change in the heart failure. That is 2D echo abnormalities are there. Any biochemical abnormalities are there. But there is no per se any symptomatology present as heart failure. That is stage B. Stage is symptomatic heart failure. Stage D is advanced heart failure where patient requires hospitalization. These are the classification of heart failure. These are about ACC 2022 guidelines, American Heart Association guidelines 2022. So this is how you diagnose the heart failure. First you suspect the heart failure. So what are the risk factors? Whether the patient have diabetes, hypertension, some obesity, some smoking, some alcohol history is there. So they are predisposing factors to heart failure. So then any symptoms and signs of heart failure. So like left heart failure symptoms. There is a pulmonary edema is there. So any cough with sputum is there. Or any low BP is there. So these are any fatigability is there. So they are all suggestive of left heart failure. Whereas right heart failure, you'll have more of congestive symptoms like hepatomegaly, congestive hepatomegaly, or pedal edema, raised JVP, or abdominal distension. These are all suggestive of right heart failure symptoms. So these are all signs and symptoms of heart failure along with any abnormal ECG is present. So any pure RV progression is there, left ventricular hypertrophy changes are there, or any old QS complex are there, any ST elevations are there. These are all suggestive of abnormal ECG findings, any left axis deviation or something like that. These are all should raise a suspicion. First risk factors you should assess, then any signs and symptoms are present, then ECG findings. Then get if possible NT-proBNP and BNP. NT-proBNP more than 125, BNP more than 35. So biochemical markers, if they are present, then go for echocardiography. So if it is abnormal finding, it is diagnosed as heart failure based on the echocardiography findings. You can call it heart failure with reduced ejection fraction or mildly reduced ejection fraction or preserved ejection fraction. So this is how you diagnose and how you approach a case of heart failure symptom. This is for ESC guidelines, ESC 2024 guidelines. So what are the biomarkers we generally use is BNP, anything more than 35 or more than 50, and NT-proBNP more than 125 picograms per ml, or high sensitive cardiac troponin anything more than 99. So that is normal values considered as these are the biomarkers suggestive of heart failure. So these are helpful to identify. Most of them are elevated in the stage B heart failure only. They are elevated in stage C and stage D. They are helpful in both diagnosing and prognosticating the patient. How is the progression? Also will helpful in with these biomarkers. So how you diagnose heart failure with preserved ejection fractions? There are various key variables that are, so always when you are looking at the echo, one is you look at the EF is there, then you look at the mitral valve, aortic wall, for the stenosis or any regurgitant lesions are there, that you can look at. Then how you diagnose heart failure with preserved ejection fraction is the main thing. First you look at left atrial volume. So left atrial volume should be more than 32 ml per meter square. So then mitral E velocity and E by E prime velocity. So E by E prime, what is E by E prime? I will explain when the TDO echo topic again. But the any E by E prime more than 9, ratio is more than 9, is suggestive of heart failure with preserved ejection fraction. So these are all the various objective evidence of heart failure with preserved ejection fraction where there is diastolic filling or increase in left ventricular pressure per se. So one is left ventricular mass index more than 95 grams per meter square in females or more than 150 grams per meter square in the male. So left atrial volume more than 34 ml per meter square, or E by E prime ratio is the more than, and is the most common and most specific and sensitive, one of the most specific and sensitive used for heart failure preservation. E by E prime more than 9, and NT-proBNP more than 125, or BNP more than 35, and these are the common markers that are there in the heart failure preserved ejection fraction where LVEF is preserved, but there is a heart failure per se. So these are the markers you can use see in the 2D echo to label it as heart failure with preserved ejection fraction. One is the most common thing is E by E prime more than 9 and left atrial volume more than 32 ml per meter square. So what is the general recommendation? First, you advise a physical activity that combine both aerobic and anaerobic physical activity you should advise, and also advise the serum potassium should be continuously monitored. So any rise in serum potassium is associated with the predicted mortality in heart failure. Avoid smoking, avoid the dietary salt. Dietary salt should be restricted to less than 2.3 grams per day. So dietary salt should be less than 2.3 grams per day. Even if the symptoms are still present, you can restrict to less than 1.5 grams per day. And also restrict the fluid intake to less than 1.5 to 2 liters per day. This is one of the most common thing we don't advise the patient. Salt restriction and fluid restriction has significant symptomatic benefit. So always restrict the salt intake to less than 2.3 grams per day, and also fluid restriction to 1.5 to 5 liters, 2 liters per day. So also avoid alcohol intake and all. So these are the various dietary recommendations you can advise. One is the decrease the like always there are two kinds of diet. One is DASH diet where you advise vegetables, fruits and whole grains and low fat milk products and nuts, fish and lean poultry. This is the DASH diet where you can so you can see vegetables, fruits and whole grains, fish, poultry, beans, nuts and seeds should be advised. Avoid any fatty meals and full fat dairy, and also carbonated drinks should be avoided. Any excessive sodium intake, these are all should be avoided. This is the DASH diet which is advised in the case of heart failure patient. And also Mediterranean diet is one more thing which has high amount of monounsaturated fatty acids where you consume high amount of fruits and veggies and whole grains, and also where high amount of fibrous food is there. And also advise at least one serving a day in the case of fish and seafood or nuts, and should be consumed in at least one serving in a day. And also limit to once per week. This is the poultry, mainly poultry or low fat dairy eggs should be one serving per week. So sorry, this is one serving per day. This is at least 3 servings per week. So limit to one serving per week is at least red meat and all high carbonated and sweet should be restricted to one serving per week. At least one serving per day is the poultry and low fat diet and eggs and all. At least 3 times servings a day is fish, and 3 servings in a week is fish and also lean mass and nuts and legumes. Every meal you should consume at least some amount of fruits and veggies, the Mediterranean diet. So Mediterranean diet and DASH diet is one of the most important thing that is followed in the case of heart failure. So how do you manage hypertensive management? A major cause of heart failure in the up to 91% of patients have hypertension in them. So intense blood pressure control has shown reduce the heart failure risk by 36%. So the most commonly used again in the case of heart failure in the hypertension management, the AC inhibitors or ARB inhibitors. Now recently there is the sacubitril valsartan also, that is ARNI, that has been recently come up in the heart failure management. So in the stage B heart failure, where this is initial stage A where you manage the pre-corbon, you should control in the stage A, and the diabetes should be adequately controlled, heart failure should be controlled, any obesity, advise the dietary changes and also weight reduction and all. So you can prevent, any statin can be prescribed as per the diabetes risk and heart failure risk. So you should monitor the lipid profile and also routinely monitor any anginal symptoms are there. You can get a TMT done or angio if needed. So based on that you can routinely monitor this patient. Stage B is where there is structural heart disease and cardiac biomarkers are elevated. So in them advise always enalapril, which is solved study, and capital based save study, reduce the heart failure predominance by 20%, 30% respectively. So these are the AC inhibitors and plus beta blockers should be advised in the case of stage B heart failure. When though per se patient doesn't have any symptoms per se, but when you do the routine 2D echo or routine biomarkers, there are significant change. So in them you should definitely advise AC inhibitors and ARB inhibitors plus beta blockers in all of these patients. They decrease the progression of symptomatic heart failure. So there is also one more, the Capricorn study and River trial, which are the beta blocker study. They also reduce the cardiac remodeling and also reduce the cardiovascular related mortality. You need to learn all of these studies like enalapril salt study, captopril save trial, and Capricorn trial, carvedilol, River trial, metoprolol. These are all the heart failure studies that are there. But any heart failure in the stage B where there is no symptom per se, you should always advise ACA plus ARB plus beta blocker, AC or ARB plus beta blocker. So what are the AC and ARB are the preferred in the management of stage A or stage B heart failure with type 1 or any diabetes, hypertension and all. Or also albuminuria also present. And also treatment with thiazide diuretics after the AC and ARB inhibitors. So after that you should need to add thiazide diuretics and AC inhibitors has should to be more effective than adding a calcium channel blockers. If still the BP is still high or something, you can add a thiazide like diuretic. So it has shown benefit in the case of symptomatic heart failure. So these are the various pharmacological therapy, especially in the stage C and stage D. Initially stage 1, AC or ARB inhibitors plus beta blockers. If required, thiazide diuretics can be added. In the stage C and stage D, all these patients where symptomatic heart failure is there, advanced heart failure is there, you should definitely add all of these drugs. One is beta blocker, AC or ARB or ARNI is recently coming up. ARNI replaced AC and ARB in the present day guidelines. If in heart failure you have to choose between AC and ARB, you should always choose AC inhibitors over ARB because AC can cause and decrease the preload also. Why AC decrease preload? You read about it and tell me. And AC and ARB or ARNI, in heart failure ACs are preferred, whereas in the case of hypertension ARBs are preferred when compared to ACs. And mineralocorticoid receptor antagonists and SGLT2 inhibitors. These all drugs should be added in the case of heart failure with reduced ejection fraction. So all these, it's like diuretics can also be added for symptomatic benefits. So these are all drugs, and aspirin and statin along with the, based on the CV risk, you should add aspirin and statin also. So mainly for management, beta blocker, ARNI or AC or ARB, mineralocorticoid receptor antagonists and SGLT2 inhibitors. These are all should be part of your treatment guideline. So ARNI with the development of ARNI sacubitril valsartan, 49/51 is there, 24/26 is there. So replace the AC and ARB inhibitors. So sacubitril valsartan, which is a neprilysis inhibitor plus ARB, there is evidence of benefits in heart failure superior to AC inhibitors. So it has shown associated with 20% reduction in the cardiovascular death and heart failure hospitalization compared with enalapril. So sacubitril valsartan is more significant to reduce cardiovascular. Generally, ACRB inhibitor itself can decrease the cardiovascular mortality by around 18 to 19%. So it added a benefit of 20% more. So around 39 to 40% improvement is there in heart failure mortality and cardiovascular death with sacubitril valsartan, that is ARNI, when compared with only 20% is seen with AC or ARB. The side effects of ARNI inhibitors are mainly hypertension is more common, that is first dose effect is most commonly seen, hyperkalemia can be seen, any kidney function should be monitored, drug should not be used with the history of angioedema. So these are the hyperkalemia and kidney function and angioedema should be looked for. So mineralocorticoid receptor antagonists, like generally steroidal mineralocorticoid antagonists like spironolactone and eplerenone have shown the reduce the cardiovascular death and hospitalization of heart failure and heart failure with reduced ejection fraction. So however, diabetes with risk of hyperkalemia and especially with the diabetes CKD is there, they might have hyperkalemia and AK. In this case, you should closely monitor potassium and creatinine level and then give. But they have shown reduced cardiac remodeling and also reduced the cardiovascular mortality and hospitalization. Definitely, if possible, you should add mineralocorticoid receptor antagonists also in heart failure with reduced ejection fraction. You generally add Lasix and all, but add aldactone also. Generally, we just stop with Lasix, but aldactone has mortality benefit. Lasix, furosemide does not have mortality benefit. So always add aldactone in the patient with heart failure. It has more benefit compared to the, it can cause diuresis also, it has mortality benefit also because it can decrease the cardiac remodeling and also has cardiovascular mortality and hospitalization also decreased. So beta blockers, generally 3 beta blockers are generally used. One is metoprolol. Only this is not a class effect. This is seen with only 3 beta blockers. They are more widely studied. One is metoprolol succinate and carvedilol and bisoprolol. So these are the 3 beta blockers. One is metoprolol succinate and carvedilol and bisoprolol. These are the 3 common beta blockers that have shown improvement in the left ventricular ejection fraction and reduced heart failure mortality, morbidity and also hospitalization also. Coming to the SGLT2 inhibitors, SGLT2 inhibitors has been recently approved in both heart failure with reduced ejection fraction and preserved ejection fraction. So coming to the mainly reduced ejection fraction, they can be used from stage B also. So stage B with diabetes, you can add SGLT2 inhibitors. There are many trials, EMPIREC trial is there, DAPA HF trial is there, CANVAS trial is there. There are many trials that have shown SGLT2 inhibitors. Most commonly, dapagliflozin 10 mg is what we commonly used. So it has significantly caused natriuresis and diuresis and caused significant cardiovascular mortality and morbidity and also decreased proteinuria also. So DAPA HF tried, Socrates trial with sotagliflozin. So the diabetes SGLT2 inhibitors should be included for all asymptomatic patients with, especially with type 2 diabetes, should be added for all the heart failure patients. So these are the various things. The other therapies that are used in the heart failure with reduced ejection fraction, most commonly we discussed about the AC, ARB or ARNI inhibitors, and then we don't leave the heart failure management. Just you started cardes 2 mg, like ramipril 2.5 mg you started now. You don't stop at that dose. You go for the maximum tolerable dose. Every 2 weeks you should increase the dose, double it and see till the patient is able to tolerate. Then only the benefit will be there. You should go for higher doses until the patient is tolerating it, so that he'll have significant benefit. You can't just start, I started cardiac 2.5 mg, that is enough. You have to increase the dose every 2 weeks. That goes with both beta blockers and AC inhibitors, so that you can increase the dose to the maximum tolerable dose, then he can get the maximum benefit. You just start metoprolol 25 mg BD2, that is enough. Not, you can't stop that. You have to increase titrate the dose upwards, so that whatever maximum tolerable dose is there, then the maximum benefit can be seen for that patient. So the patient is at maximum tolerable dose, like you can go for ivabradine. Ivabradine is generally used after using all the AC inhibitors, beta blockers. Still the heart rate is more than 70 beats per minute, you can try ivabradine. Generally, routinely as the first line drug, ivabradine can't be used. Generally, after receiving all the beta blockers, all are used for rate control. Beta blocker is what we use generally. After using beta blocker also, after maximal tolerable dose also, if heart rate is still more than 70, you can try ivabradine in these patients. And then one more thing is a combination of hydralazine with isosorbate budinitrate. This is commonly used as an alternative for AC or ARB inhibitors when you can't use in the case of CKD patient. When there is significant creatinine elevation and also hyperkalemia is there, you can use AC inhibitors or ARB inhibitors or can't be used, then you can replace that with isosorbate dinitrate with hydralazine. And loop diuretics can also be added. So combination of hydralazine and isosorbate dinitrate is useful in alternative ARNI and AC inhibitors, ARBs, in specific condition, particularly who developed hyperkalemia and worsening renal function. Verostigmine is soluble guanyl cyclase stimulator, which is also studied in the treatment of heart failure with reduced ejection fraction, but should only be used after all the guideline management. So this is the last line drug. Verostigmine can be used in heart failure with reduced ejection fraction, which is a guanyl cyclase agonist, but this can also be used. But first is ACR, ARB inhibitors, beta blockers, mineralocorticoid receptor antagonists, and also SGLT2 inhibitors are the first line drugs. If ACR and ARB cannot be used because of hyperkalemia or CKD, you can try isosorbate dinitrate with hydralazine. If rate is not controlled after beta blocker maximum tolerable dose, you can try ivabradine. And for symptomatic benefit, you can always add loop diuretics, and also statin and aspirin can be added based on the cardiovascular status. And also always titrate the ACR inhibitors or ARB inhibitors dose, titrate upwards until the maximum tolerable dose is achieved. You can't leave it lower dose possible. Also that goes with beta blockers also. So heart failure with preserved ejection fraction, recently 2023 guidelines SGLT2 have been approved for recommended for heart failure with mildly reduced ejection fraction and heart failure with preserved ejection fraction also. It prevents the postmortem heart failure hospitalization and also reduce the heart failure related costs also. The trials are Deliver and Emperor preserved trials to reduce CV death and also heart failure hospitalization. So dapagliflozin and empagliflozin are more commonly used in the heart failure with preserved ejection fraction. Till now only they are used in the heart failure with reduced ejection fraction. Now preserved ejection fraction and mildly reduced ejection fraction also SGLT2 inhibitors have been approved. This is updated in 2024 update guidelines in ESC guidelines. So SGLT2 inhibitors have been approved in the case of preserved and mid-range ejection fraction also. ARNI, even ARNI is approved in the case of 2024. Paragon HF trial prior to the heart failure. Prior it was thought that a heart failure linked to the increased cardiovascular event. Sacubitril valsartan reduced the new loop diuretic requirement as also NT-proBNP levels. So in recent trials, sacubitril valsartan is also reduced the loop diuretic and symptomatic benefit, also reduced NT-proBNP levels. Even Paraglide HF reduced the NT-proBNP levels, also risk of worsening renal function is seen. But combined studies have shown reduced total worsening of heart failure event and CV death, especially if LVF is less than 60%. So ARNI can also be, sacubitril valsartan can also be used in the case of heart failure preserved ejection fraction, especially monitoring the renal parameters should be monitored and can be given. So both sacubitril valsartan and also the SGLT2 inhibitors have been approved in the case of heart failure with preserved ejection fraction. So even mineralocorticoid receptor antagonist is one neutral trial, that is TOPCAT trial, and structural trial is also improved exercise capacity and E/E' ratio is also improved. So meta-analysis showed reduced LV volumes, LV mass, they decrease the cardiac remodeling. So mineralocorticoid receptor antagonists have also been used in the case of heart failure with preserved ejection fraction. So HFPEF you can use SGLT2, ARNI and MRA. But MRA and ARNI you should monitor the renal parameters and hyperkalemia. These are recent update from the ESC guidelines 2024. Semaglutide is one more drug that is GLP-1 analog, significantly decrease the weight and also increase the quality of life. It decreases the reduced NT-proBNP level also, that is STEP HFPEF trial. That is STEP HFPEF trial is a semaglutide trial. So this can also be used. Semaglutide can also be used, especially in the obese patient and type 2 diabetes patient. You can try semaglutide also to decrease the cardiovascular in the heart failure with preserved ejection fraction. So these are the various drugs that can be used in the case of one is semaglutide can be tried, SGLT2 inhibitors can be tried, mineralocorticoid receptor antagonists can be tried. The other is ARNI can be tried in the case of heart failure with preserved ejection fraction. So this will reduce the heart failure in the heart failure. SGLT2 inhibitors are the first line drug in that, especially type 2. So let's say a type 2 diabetes patient came to you with the CAD or something, or heart failure is there. First line drug is always SGLT2 inhibitors, independent of HbA1c, independence of the glucose lowering medication. For additional control, you can add GLP-1 agonist if the patient is obese or something. Sitagliptin or linagliptin can be added, metformin can be added, insulin, basal insulin can also be added. These are the second line drugs. So these are the second line drugs, but these are the drugs you can add later. So these are the various treatments you can use in the case of stage A, mainly primary care, and also health and physical activity should be advised, and monitor the NT-proBNP and also cardiac troponin. For medical management, you can add, if the hypertension is there, AC inhibitor, AC or ARB inhibitors plus beta blocker can be advised, and optimize the glycemic control with SGLT2 inhibitors and metformin and GLP-1 agonists. In the stage B, avoid DPP-4, thiazolidine and sulfonylurea in the stage B heart failure. For medical management, you can use ACE/ARB inhibitors, SGLT2 inhibitors, metformin, and also for BP you can use beta blockers also, and also advise dietary changes and monitor echocardiogram. Stage C, very symptomatic heart failure, you should always avoid DPP-4 inhibitors, thiazolidine and sulfonylureas. Always SGLT2 is the first line drug. Metformin can be added. Then go for insulin basals or something. Insulin, you can use insulin, and also even GLP-1 analogs can be for diabetes management. For heart failure management, if reduced ejection fraction is there, AC, ARB or RNA should be added. Beta blocker should be added. SGLT2 should be added. Mineralocorticoid receptor antagonist can be added. Loop diuretic can be added. Aspirin and statin. For preserved ejection fraction, you can add SGLT2. Sacubitril valsartan can be added. Mineralocorticoid receptor antagonist can be added. Semaglutide, if especially obese or diabetes is there, you can add. So for other benefit, you can add other comorbidities. You can add supplement manifest. Other cardiac medication, other medication should be added for the other disease. If any comorbid, the CKD is there, for that also you need to manage. Because heart failure with preserved ejection fraction is mainly a comorbid driven condition. That might be related to CKD or OSC or something is there, that is driving this heart failure with preserved ejection fraction. Let's say CKD is there is left ventricular hypertrophy is there, that is causing the main heart failure with preserved ejection fraction. So you should treat the primary cause of CKD first. Like that, OSA can also cause heart failure with preserved ejection fraction. So there are many other hypertension cause concentric LVH and all. So you should treat the other disease also along with heart failure with preserved ejection fraction. So it is a comorbid driven disease. So whereas stage D, you can manage the same and also cardiac retransplantation, and also assist device can be conducted. So about the assist device, what is cardiac resynchronization therapy, I will discuss in the later topics, but this is the management of heart failure. Thank you.